something goes wrong, subtle warning signs of complications after TAVR and/or transcatheter mitral valve repair.
Good afternoon, and thank you so much, Major Higgins. That was fascinating, very, very, very interesting. And thank you to our men and women here in uniform. We really appreciate your service, and I can't say it enough. We are so honored to have you here. So today I'm going to talk to you about when something goes wrong, subtle signs and symptoms to look for following our MitraClip and TAVR patients. And so the reason I think this is an important topic is because I see a number of you out here today who have at some point or are likely to in the future be directly responsible for caring for these patients at the bedside. These patients that have these procedures, they go through a number of the units before they're discharged home. So these patients will start off in DCU where telemetry nurses will prep them for their procedures. And then they will then go to the cath lab where our wonderful cath lab nurses have hands-on taking care of them during their procedure. They will be then admitted to the ICU where our ICU nurses have been recovering these patients for years now. And then transferred to telemetry where they will then be, God willing, discharged home. And then as early as last year, our PACU nurses started to recover some of our TAVR patients through the Fast Track program. And then are immediately admitted to telemetry 4 hours later, where our tele nurses will then resume care. So what I want for you guys to take away from this is to be empowered and to feel comfortable taking care of these patients. And I want you to anticipate the potential for complications and hopefully pick up on some of the early subtle signs and symptoms before things could go pretty bad. And so what is our typical demographic for these patients? These patients historically, up until recently, have been identified as patients who are just too high risk to undergo open heart surgery. So these are going to be your patients who are advanced in age, multiple comorbidities, they're frail, they've probably had prior open heart surgeries before, and are clinically unstable. So these patients are presenting to us and are already at an increased risk to develop complications. So it is the job of the structural heart team to really identify these patients' risk factors and take that into consideration when we decide to move forward with these catheter-based therapies. So our structural heart team, we're comprised of interventional cardiologists, cardiothoracic surgeons, echocardiographers, nurse practitioners, structural heart coordinators. So there's a number of specialties that come together and talk at length about each and individual case to make the best choice for these guys. So, and the great thing about TAVR is that since its FDA approval in 2011, the complication rates have significantly improved with each passing year. So this procedure is becoming safer and safer for our patients. But I want to impose upon you is that the complications are still a very real possibility. And the ones that I'm going to talk about today are some of the more common ones if they do occur. So when we're talking about complication risks of TAVR, we're talking vascular access complications, conduction abnormalities, acute kidney injury, stroke, and pericardial effusion. And we're talking MitraClip, we have concerns for potential for major bleeding due to vascular access complications, cardiac perforation, there is a potential for stroke and device-related complications. And less commonly with our MitraClip patients, acute kidney injury, because we don't use contrast during these procedures. So for vascular access complications, what you're at a heightened risk for is if you have severe atherosclerotic disease. So moving the catheters along a very heavily calcified aorta is going to definitely increase the risk for perforation, bleeding issues, that sort of thing. Of course, higher arterial sticks also increases that risk factor. So the most common complication with vascular access is going to be a hematoma formation, followed by a pseudoaneurysm and a retroperitoneal bleed. So when you're monitoring these patients, the first and most subtle thing you may start to see is tachycardia and hypotension. So these are going to be the two triggers that if you're noticing a trend in this, it's getting worse, increased vasopressor requirements, you should already be on alert that something is happening and we need to maybe look into this a little more. And then of course if the patient starts complaining of abdominal pain, back pain, groin pain, you should almost immediately start to think there's something going on bleeding wise, let's check the access sites, that sort of thing. Worsening anemia, diaphoresis, diminished or absent pulses, and ecchymosis, that's not exactly an early sign, and nor is it exactly subtle. So if you do notice some emerging ecchymosis, there's a high chance that this patient probably had some hemodynamic compromise preceding this. So hopefully this is something you noticed before we got to the bruising part. So treatment and management of this, nurse-to-nurse handoff, this is very, very important. Our cath lab nurses are so wonderful with really establishing a good baseline. What kind of pulses did this patient have going into this? What did their access site look like when they got them off the table? Together, eyeball the access site and really establish a good baseline so that you can delineate from any changes that do occur. Ongoing hemodynamic and cardiac monitoring. So those are very, very important, especially within the first 4 to 6 hours, because you can then start to trend the vital signs and assess for any changes. Of course, we do stat labs when these patients roll into the recovery area, and then we do labs 4 hours later just to see if there had been any changes as well. Frequent access site and pulse checks. Within the first 2 hours, we need to be at least checking the pulses and access site every 15 minutes, followed by every 30 minutes for 2 hours. And then of course, if you do notice ecchymosis, obviously outline it with the marker so you can assess for any changes. Strict bed rests for these patients are very important. They had a major large bore catheter in one of the major arteries of their body that was recently removed. So these patients need to be laying flat for 6 hours. And some of us know some of these patients have a hard time laying flat. So patients that are combative, delirious, hitting, punching, sometimes we use anxiolytics and pain meds just to kind of bridge them, at least to get them through the 6 hour span so we can, reduce their risk. And then of course, if you do notice some bleeding, sometimes this is something as simple as just managing with just applying manual pressure anywhere between 15 to 30 minutes at a time. But we need to be notified if this is occurring because these identifications of the vascular access issues, they can become catastrophic. These patients may need to go back to the cath lab, and in some cases, they do need to have surgery to fix this. This is definitely a later sign, so please don't let this happen before you call. This is a pseudoaneurysm from a radial access site. Again, this is another late sign. This is the Gray-Turner sign and Cullen sign that you would potentially see with a retroperitoneal hemorrhage. So, conduction abnormalities, this is more synonymous with our TAVR patients. So patients who present with a baseline bundle branch block, we anticipate these patients have a much higher risk for developing conduction issues. So patients who present with a right bundle branch especially are going to be a concern. And as we're working these patients up prior to moving forward with the procedure, we're very transparent about the potential that these patients could actually be discharged with a pacemaker. And as I had mentioned earlier, complication rates from TAVR are improving. Unfortunately, pacemaker placement rates are the only complication that has increased since its FDA approval. So that's been on the rise. So, and this one's a little more straightforward. So, conduction abnormalities, you'll identify them on the EKG. You'll be seeing some changes. The conduction abnormalities that we really have concerns about are the patients developing a prolonged PR interval, new bundle branch block, and of course complete heart block. These are going to be the patients that we're going to want EP on board almost immediately because the risk for developing complete heart block down the road is at an increased risk. And then of course other symptoms with conduction abnormalities, lightheadedness, dizziness, shortness of breath. They may be bradycardic, they may be tachycardic, especially if there's a new onset AFib, nausea, palpitations. So be be mindful of that. And for management and treatment of these patients, we require a continuous cardiac monitoring. You know, if you do identify any kind of EKG changes, we get a stat 12 lead just to see, you know, establish the before and the after. We do, for patients who have the transvenous pacers following our TAVRs, we maintain them for at least 24 hours because the potential for developing the issues, we'd like to have that security blanket with the transvenous pacer before we place the pacemaker. And then of course new onset AFib, that's kind of straightforward. We start them on blood thinners even as early as the evening of their procedure, and antiarrhythmics. And then of course if clinically unstable, we will cardioport these guys. So acute kidney injury, again, this is more related to our TAVR patients because there's a lot more contrast required with this procedure. Patients who are at an increased risk for this, patients who present with an underlying kidney disease. And again, as part of the transparency of the workup process, you know, we discuss the potential that their kidney function could get worse. We work very closely with the nephrologist to predict that risk. And patients where dialysis is a hard no, this is not something they would ever be interested in, that is a very serious conversation we need to have if they're considering TAVR, and maybe consider doing just conservative medical management for these guys, because the potential for increasing for dialysis is real. So causes for this is contrast-induced nephropathy, and then of course hypotension. So, you know, the kidney is a pretty needy organ when it comes to perfusion. So if there's any hypotension, which we do see with our rapid pacing when we're deploying the valve, hypotension with the initiation of anesthesia, any kind of lower blood pressures are going to increase that risk. And blood transfusion, interestingly, are also linked with increased risk for AKI with our patients. So the first and early signs and symptoms of this is going to be your low urinary output. And you can have a low urinary output from the injury as early as the first couple hours. So watch low urinary output, dark concentrated urine. Patients will have worsening renal function. They'll have an acid-base imbalance, metabolic acidosis. And then, of course, later stages, you know, they may develop fluid volume overload, which is with your pulmonary edema, your shortness of breath, so on and so forth. So in order to try to reduce this from occurring, our patients who do present with chronic kidney disease, we do try to hydrate them with IV fluids prior to their procedures. And then, of course, everybody gets IV fluids following their procedures just to help flush the kidneys. For these patients, we do try to limit contrast as much as possible. Try to space the time. You know, these patients do get CAT scans, CTAs, they get the angiogram prior to their TAVR. So we do try to be respectful and space the time from each exam appropriately. Of course, stat labs are obtained, hourly I's and O's for these patients. And try to wean your vasopressors as soon as possible because, you know, the vasoconstriction from your vasopressors can be nephrotoxic. And in cases where your renal function is getting worse, we'll get a nephrology consult. We will dialyze and CRRT if needed. So for stroke, with TAVR, the stroke is most likely related to embolism of the debris from the calcifications. It's less likely of a thrombus formation, though that does occur. And so the unfortunate thing with that is that they're not very responsive to lytic therapy. But would we ever TPA a patient who just had a major catheter in one of their arteries a few hours ago? Absolutely not. So the unfortunate thing is with patients who do develop strokes with TAVR, we're a little bit limited in the treatment for them. So there is an emphasis of prevention for this. And actually companies are now developing filters that we can implant during the procedure to help catch some of that debris in order to prevent embolization of that. And then of course, resuming your anticoagulation for patients who had AFib as soon as it is safe from a bleeding perspective. And again, this is something I usually start around the first night that they're there. So Oh, here's some examples of the embolic protection devices. So pericardial effusion, this is going to be more associated with any kind of cardiac puncture. So patients who are going to present, you're going to see early signs and symptoms of the tachycardia and hypotension. And also they may become short of breath, they may have chest pain, increased central venous pressure, and if you think way back to your nursing health assessment, these patients can develop Beck's triad, so muffled heart tones, jugular venous distension, and hypotension. These patients can also develop pulsus paradoxus. And so that is going to be identified using your arterial waveform. You would see a 10-point drop in their systolic pressures with the inspiration. You'd see some EKG changes. They may have low voltage. They may have electrical alternans. I'll show you an example of that here in a minute, where the QRS amplitude decreases and increases with each heartbeat as the heart flows in the collected fluid sac. So I'll show you an example here in a sec. But if there is any concern that the patient is developing a pericardial effusion, we get a stat echo. So we do an echo prior to these procedures completing. We do one the next day, just a limited echo, just to make sure there is no fluid collection. And then we will do one if there is any question or concern for a pericardial effusion. So continuous hemodynamic monitoring is very important, and if there's just a small fluid collection, that really shouldn't cause any degree of symptoms or hemodynamic compromise, but when you start to get that right ventricle compression, that's when we're going to need to start doing something. So these patients may end up getting a pericardiocentesis, a pericardial window, and in, again, some rare cases, they may have to go for open heart surgery to correct whatever was injured. So, all right, so this is an example of the pulsus paradoxus that you would identify using your arterial waveform. So you can see with each inspiration, the waveform decreases. And here's your electrical alternans on the EKG. Okay, so my point of emphasis here is I really want you guys to be vigilant with your health assessments. Make sure that you're doing them frequently. And I want to really make sure that you do establish a baseline when you do get your nursing handoff so that you can delineate from any changes. And because, you know, the earlier you recognize the problem, the earlier we can intervene and improve the patient's outcomes. And if there is ever any question or concern that you ever have, you know, something doesn't look right, you know, please just always call. Always call any one of these guys that you see up here on the screen. They will come right to the bedside. And help out. And the one that is likely to get there the quickest is probably going to be this guy speeding through all the red lights. So, all right, thank you very much.
Great job, Shelley. Does anybody have any questions for Shelley? Wow, you covered that. Good.
Oh, well, thank you. Thank you very much.